Can you see the
Okay,
presentation?
perfect.
Yeah. Okay. Good. So the general idea is to develop a diagnostic tool for Hirschsprung disease to improve both accuracy and speed of diagnosis. I'll start with a little bit of background that I'm sure most of you know. So Hirschsprung disease is the lack of ganglion cells in the distal intestine, sometimes the entire intestine. It leads to intestinal obstruction. The treatment mostly is surgical resection of the affected segment, and we need accurate diagnosis because overdiagnosis leads to loss of functioning tissue, and underdiagnosis may lead to requirement for repeated surgical treatments. So we need a pathologist to make accurate diagnosis and to identify the area where there are ganglion cells. And this is a very big challenge. Actually, Rami mentioned it at the beginning. The choice of Hirschsprung disease was because we asked pathologists what is the most challenging task that you encounter, and many of them said Hirschsprung because they have to go through dozens of slides to identify very very small event of ganglion cells. So the recommended number of slides, it's really dozens, like 70 cuts from the tissue, and the size of ganglion cell is like 1 in 10 million of the entire area that the pathologists need to screen. So it's a big challenge for pathologists. There is a lot at stake because we want to make the most accurate diagnosis, and it's also a big challenge computationally. So the combination of all of these elements led us to choose this as our first challenge for applying AI. And an important requirement for applying AI to Hirschsprung is that the slides would be digital. So about 8 years ago, we moved from looking with microscope at glass slides. We moved to whole slide scanning, and they are becoming the routine in many pathology labs all around the world. And this really opened the opportunity for applying AI to image analysis. But by the way, if you have questions throughout the presentation, please feel free to interrupt and to ask. So our research objective was to develop an AI-assisted tool to detect ganglion cells. And we hypothesized that it would reduce diagnostic errors, and it will also reduce diagnostic time. So what we did, we started with a annotation of ganglion cells. So we took 95 digital slides and made annotations and 9 cases from samples from patients with Hirschsprung disease. And we made annotations very meticulously and annotations around each ganglion cell that was present there. And also we marked areas that did not contain any ganglion cell for the training. And so this was the initial training. Then we evaluated the algorithm on 10% of the database to make sure that it identifies ganglion cells accurately. And finally, we applied the algorithm to real clinical cases. So we applied it to clinical cases, and so if the algorithm could identify the ganglion cells in all the cases where there actually were ganglion cells. And
One question, Doug.
yeah, yes.
How did you come up with 95 as the number to evaluate?
Um, I would say that maybe Rami will touch on that in the next slide. The big challenge in Hirschsprung diagnosis or in developing algorithms for diseases such as Hirschsprung disease is that we have very small amount of data. Okay, usually when we are talking about algorithm development for image analysis, the algorithms are based on huge amounts of data. If we look specifically in pathology, so the main algorithms that were developed are for prostate cancer and for breast cancer. So the most common diseases. And for Hirschsprung, it's a big challenge, and we took what was available. So we knew that this would be a big challenge, and part of the challenge is to develop an algorithm based on relatively small amount of annotation using a unique algorithm developed technology that Rami will touch next. So we didn't do any power analysis or calculation to decide on these 95 cases. We took what we had, what was available, and Rami used his magic to develop a useful algorithm, and maybe now is the time for Rami to explain
Yes, I'll explain a
a
bit
little
more
bit
about
more.
it. So can you go back to the previous one just to say tell something about the numbers? So 9 Hirschsprung cases, that's approximately what Dov could provide back then. And then we took 10 times normal adult colons. So it's
Okay.
and they are very different. They don't look the same because in that early stage the colons are still developing, so they are look very different. So we didn't know if how much it's going to help us in actually analyzing the Hirschsprung cases. We did knew that we have very few cases to deal with. So we could push 10,000, but it would not change the power of the mechanism. So it's just 10 times what we had in the Hirschsprung cases.
And one other question. Why not look at pediatric colons, normal pediatric colons?
We don't usually take those out.
Sure.
Like there's
But
really
so there's no availability of samples is basically the answer.
Yeah, it would be really rare, like trauma or something like that. But yeah, exactly. We don't have many samples. We have small biopsies, but they don't represent the full thickness of the intestinal wall. So these samples are not really relevant for Hirschsprung diagnosis, and larger bowel resections are quite rare. Yeah, maybe even more rare than Hirschsprung.
But what you could use is the proximal normally innervated bowel from Hirschsprung's patients.
Yes.
Because we do take that out.
Yeah.
Okay.
Yeah.
Those the small sample size and the adult versus pediatric stand out to me as just curiosity.
Yeah, but I will touch that in the next 3 slides. I'm going to explain a little bit about what is going on. So, Dov, can you move to the next slide? So why the problem is so challenging? Why Hirschsprung specifically is so challenging? In a single slide, when you make it digital version, then you have 100,000 by 200,000 pixels in each such slide. It is equivalent to about 5 minutes full HD video. And inside it, there are very extremely rare events, which is the ganglion cells. The size of that is about 50 by 50 pixels, so it's about a thumb somewhere in the movie. And then it will appear for a single frame, and then you have usually dozens of those movies. So it's very easy to lose such an event or to miss it. And then the shape of these cells are very irregular because of the stage of development of the colons. So when human pathologists learn about how to analyze this case, they are given few examples of how this look like, and then they need to deduce what they see in real cases. So we started with this idea in mind. So no human beings trained to diagnose Hirschsprung disease got more than that. No one get more than 95 full slides, fully analyzed. All the data is available in order to figure out how to do his task. And we ask ourselves if in more amount of data than what usually pathologists get to analyze these cases. So we do know that human pathologists are struggling to achieve high quality, consistent results, and we try to achieve better results than them. So that was the starting point. You can move to the next slide. So when we think about humans and modern AI techniques, there are clear strengths to humans relative to AI. So no AI techniques work in a fashion that an expert pathologist work. They are not given few examples, few sentences to describe what is so special about Hirschsprung disease, and then let the computer figure out what is going on. Usually, in order to make such algorithms work, you need to provide tons of data, tens of thousands of slides and annotations, and this simply doesn't exist in the whole world. So even if you could collect from all around the world all the Hirschsprung cases and annotate them, you will not have enough data to the way modern AI algorithm works. So we were in the state of mind that we must develop something new. We must develop something different than the way it works. Then when you think about the main weaknesses of human analysis, this is subjective, time intensive, prone to fatigue, and very limited throughput. This is all can be overcome by algorithms. So this is the good news. So if you succeed to build algorithm that can actually overcome the main human weaknesses, then you will have powerful. But then when you look at the weaknesses of AI, then they cannot work in those conditions. There's not enough data. The cases are very special. They are not the normal case of ganglion cells. And then where will you get enough data? You're not going to get it. So you need to develop new algorithm in order to move forward. But then if we do succeed to do it, then we knew that it will be very complementary to what humans can achieve. And the way we chose is to work very closely together, the human experts and the AI experts, in order to find out what can actually make it work. And you can move to the next slide. We developed a method called hierarchical contextual analysis. And then what we try to exploit is the main insights pathologists gathered in the last 100 years in how to detect and how to analyze those cases. So I personally was sitting with them in order to understand what exactly they see, how exactly they see. And then it is very interesting from my perspective to understand what is the process. And of course, we use completely different language, the pathologists and myself. But then how to imitate what exactly they are doing and why they are doing what they are doing, and what's the difference between false alarm and true positive. That was the way for us to get insights about what we actually need to develop. And one of the main things is that they use always context. They don't use analysis out of context. They don't just get a small piece of the tissue and then decide exactly what is going on. They look around. They look in different scales. They try to figure out what is the relation between that element and other elements, how it is related to things that I saw in the past, other ganglion cells, other Hirschsprung cases. It reminds them previous cases. And that's simply not the way modern AI techniques work. The way modern AI techniques works is that you just feed them with huge amount of data. And in my terminology, the main thing they are doing is just to try to memorize all those structures and try to figure out if the structure they encounter is similar enough to what they saw in the past. And as I said, this is impossible in that specific case. So it's even if you try to push that, you will not be able to get anywhere. So we combine the insights from experts, the insights that collected in the last 100 years, and use deep learning techniques in order to collect all the data that we can actually to take into account all the memory data that we can actually collect. And then I think what we achieved is that we succeed to reduce the problem of analysis of Hirschsprung disease into something which is very tractable. So we reduce, for example, a case with 70 slides, which is equivalent to 2 hours movie, full HD, 30 frames per second, into a single PDF, which tell the physician, this is the suspected ganglion cells, this is their location, this is the way they look like, this is how confident we are that this is actually ganglion cells. And in the moment you provide such a thing with almost no cost from the perspective of the physician, then you reduce the problem to something very tractable. We tested it both in multiple hospitals and in other hospitals outside of Israel. And then we see that this is consistent. So we are quite confident that this is good results. So Dov will give all the details, what we checked, how we checked. But then we will be happy to provide it as much as we will get support from the hospital to any parent that need to use it. So as long as the hospital will support it, we will be happy to share it with whoever wants. That's my part.
Can I have a question? The findings on pathology that to make the diagnosis of Hirschsprung, one is whether there are ganglion cells, but there's also the issue of hypertrophic nerves. Did you include that in the algorithm, or are you just specifically at this point looking at ganglion cells?
Yeah, no, so we focused on the ganglion cells, and actually on a nice cohort with regard to Hirschsprung disease, we saw that this was enough. Okay, so we were able to detect ganglion cells and make the same diagnosis as the pathologist. Actually, there was even one case that was misdiagnosed, and we were able to find the patient recurred after a year, and actually the algorithm made a better diagnosis. Okay, so just at the ganglion cells was enough to get to the same diagnosis in multiple hospitals as the pathologist did. I will touch on that soon, but in significantly shorter or smaller effort.
One more point. So in order now to analyze such cases, you need an expert. So not all hospitals in the world have such experts. And if you have an algorithm that can actually achieve similar performance to an expert, and you reduce the amount of load on those experts, then you can, in principle, make it accessible to many more other people in need of such an analysis. So I think it's not financially valuable, but it's valuable for many parents. So if we will succeed to make it accessible, I think it's a great achievement of that project.
Yeah, I mean, correct me if I'm wrong, Jack, but I remember way back when we were in the NICU with Adrian, and what I recall is that the process of taking samples, biopsies, and then getting the pathologist to read them while your kid is essentially, there were multiple rounds of pathology involved. So I think that's another benefit here of eliminating, the I guess the potential latency of dependency on the pathologist to read multiple different tissue samples. Although I'm
Yeah.
not.
I mean, I don't know. In Adrian's case, I don't know why they needed multiple biopsies. Sometimes it's just the adequacy of the biopsy itself, having enough tissue, and I don't think that this technology would help with that. I think you still would need an adequate biopsy to use the AI approach. But I do think sorry, Eric, go ahead.
No, what I recall, I was just thinking out loud because it's been a long time. But what I recall is that because, not all cases are total colonic,
Yeah.
as you know, so you got to find that transition zone, and that's another problem in cases. I don't know if you guys address that in your research, but finding
Yeah.
where the ganglion cells stop or start is another problem area.
Yeah, and that requires frozen sections. So I'm guessing you haven't been looking at frozen sections, but that would be something, for the additional.
No, actually we did. But yeah, we have also some experience with frozen sections. But just to comment on what you said, even our diagnostic workflow is not AI by itself. Okay, so it's a combination of
Sure.
AI and pathologist. So there are two elements. So there is the algorithm, the decision support algorithm. And as Rami said, instead of dozens of slides and a huge area that we need to scan, the algorithm reduces it to a few small images with the high magnification of the area suspected for ganglion cell and the context. So instead of huge area, it's one PDF with a few images, or the best ganglion cells proposed or suggested by the algorithm. So this is the algorithm element. Now that goes to the pathologist, and the pathologist can decide, is it a ganglion cell, give it a score. I'm certain this is a ganglion cell, or give it a lower score if they are not convinced. There is the algorithm score, and based on the pathology score and the algorithm score, we have a few options. So it can be positive, or we tell the surgeon, or we write in the report that, okay, we found ganglion cell. It can be negative, if both the pathologist and the algorithm thinks that all the images are negative. And based on the decision criteria, it can be doubt. Okay, and in doubt cases, we send just the small PDF, the PDF with the small images, to an expert in Hirschsprung disease diagnosis. So these are the three options based on the pathologist and the algorithm score. And using this, we were able to achieve 100% accuracy, okay, of the algorithm. Some directly from the based on the criteria, and some after consultation. Again, the consultation was only on one PDF size set of images. And instead of spending half an hour or sometimes more on the digital images or on the slides, it took like 15 seconds to 20 seconds just to run through the suggested images. We received 100% accuracy. So the novel contribution in our view was that it handled variable, different types of data. I will say a few words about it later. it was with high accuracy, and it also supported frozen section. I have a slide about it. And the challenges, as we said, were the slide and scanner variability. So different hospitals use different staining protocols for the slides. So there is some differences in the staining intensity, in the contrast. So the algorithm was able to deal with that. Different medical centers have different scanners, and also there is difference in the contrast and in the color intensity between different scanners. So this was also a challenge, and we were able to overcome these challenges. And obviously, we talked about the small data set and the rare targets, ganglion cells, and also artifacts in frozen section. So we were able to achieve 100% sensitivity. Some of the cases, as I said, were post-referral, 95% at least of the time saved, and even non-expert achieved 100% accuracy. Again, as I said, they had to send a few cases for referral. The reason is that, Rami mentioned it also at the beginning, ganglion cells in patients with Hirschsprung do not look like ganglion cells in adult intestine. So we see immature ganglion cells. And non-experts in Hirschsprung diagnosis have challenges identifying these events. So we had quite a few cases where the algorithm highlighted, just like the examples that we see here. These are not classical ganglion cells. Okay, so these are immature ganglion cells, and the algorithm highlighted these events, but the non-expert pathologists that view these small images mark them as non-ganglion cells. Okay, so in these cases, the algorithm gave a very high score, and the pathologist gave a low score, and the decision support algorithm would tell the pathologist, okay, in this case, you should send it to an expert pathologist to review. And this is the multi-center trial. So we took cases, quite a large cohort, as you can see, for multiple medical centers around Israel. Some of the cases were scanned by 3 different scanners. The Philips platform, the Hamamatsu, and the 3D Histotech. And as I said, we achieved, I have a slide. Okay, so as you can see, this is the same area. This is the same area from the slide.
I think you moved too fast. Can you go back?
Oh.
Can you?
Yes.
So we took data from Hirschsprung cases from different hospitals, and then we scanned them with different scanners. So it's 2 degrees of freedom, independent. One of them is the different scanners, one of them is the different hospitals and their protocols. And we took just 2 cases in order to test the algorithm. The rest of it was just for testing how good the algorithm was without any try to improving the algorithm, just checking performance. So that's it.
So the algorithm development approach that Rami used, not only that it was able to identify ganglion cells in the samples that were generated in the same hospital and using the same scanner, but we were able to generalize the algorithm and to get good results also in different hospital, different scanners. So this also attests to the strength of this specific algorithmic approach. Okay.
And who were the pathologists that you were working with?
So we worked with two pathologists in our department. Dr. Greenberg was the leader on this project, and he reviews most of the Hirschsprung suspected Hirschsprung disease cases in our department. And another one, Dr. Isaac, also was involved in the project. He also reviews many cases.
Yeah, but we get full data from the other hospitals about what was the decision regarding each one of those cases. So we knew we had a full protocol of what was going on with each of those cases.
So if we go back one slide, I just want to make sure I understand the samples coming. So Center A, there were 51 cases that were captured, right? And two of them were HD positive diagnoses. Is that how?
No.
Okay. Two cases were sent for algorithm fine tuning.
Yes.
Just first tested by the algorithm to make fine tuning of the algorithm to adapt to the specific hospital. That's it. So the rest of the cases were analyzed by the fine-tuned algorithm. So we used two cases just to fine-tune the algorithm to
two cases for learning,
yeah,
and 49 for analysis. Okay,
exactly. Yeah.
That's how we should review that. Okay, and then after that, you sent all of the cases from the 4 centers to the Philips scanner.
No, all the cases from center.
Center.
I think it was 4 from center 4.
Oh, okay, I
Center
see.
From Tel-Aviv Medical Center. All the cases from our center. I think it was Center D. I need to check it, but all the cases from our center underwent scanning by. Actually, as you can see, not all cases. All cases underwent scanning by the Philips platform. 30 of the cases underwent scanning by the Hamamatsu platform, and 49 cases underwent scanning by the 3D Hist platform.
Okay. And so in this case, we should look at on the far left, there are 51 cases from Center A, 31 from Center B, 51 from Center C, and 59 from Center D, right?
Yes.
How do those relate to the 95 cases you referred to at the beginning?
The 95 cases referred to at the beginning were not cases of Hirschsprung disease. So for the training of the algorithm, there were 9 cases of Hirschsprung disease and 95 cases of adult.
Got it. And then among these cases, are these all suspected Hirschsprung disease cases, or are they random cases where you have slides?
All of them suspected Hirschsprung disease. All of these cases from spanning, I don't know, like 10 or 15 years from the archives of the medical centers, but all these cases are suspected Hirschsprung disease. The exact fraction of cases that were eventually diagnosed with Hirschsprung disease is present in the publication. I don't have it right now. I don't remember the fraction of real Hirschsprung disease in each of the hospital, but this data I can look it up. But I would say around 50% were really Hirschsprung disease.
Okay.
And as you can see here, this is the same area in the slide. It's maybe tilted 90 degrees to this or to the other side. But as you can see, there is a significant difference in the color between the scanners. So we're talking about the same slide, and we're talking about different scanners, and you can see by the eye and by a color histogram that these pictures look different. But nevertheless, the algorithm was able to identify the ganglion cells with very good accuracy. And
I'm not sure that it's clear that the three images that you see, the three squares, each one came from different scanners. So they, okay.
Right. So you're just pointing out the variability in scanner, quality, coloration, et cetera, which you mentioned as a challenge earlier. Yep.
Yeah.
So
The same tissue, the same area, same tissue, same area, different scanner.
So the goal of those experiments was to check how robust the algorithm is in order to validate if we can deploy it to different
across all different scanner types. Right.
Different scanners, different hospitals, different staining protocols to check how robust it is and if it's valid as a solution.
Makes sense.
And as you can see, in the different hospitals, in most cases, even the non-expert pathologist was able to make the accurate diagnosis. In some cases, they had to refer the case based on the.
So the gray circles are the names are of individual pathologists, and is that correct? Or
No.
Those are medical centers?
Different hospitals.
Those are medical centers. Okay.
Yeah, these are different medical centers, and the number of cases and the correct identification is the gray area.
Yep.
And few of them required referral, but very few. In most cases, the algorithm was enough to so that even non-expert pathologist was able very easily to make the accurate diagnosis.
And then the scanner results
and also with the different scanners.
Yep.
And we also trained the algorithm to work with frozen sections. So we took samples from our department. It's a big challenge. A lot of artifacts on the slides. It looks to the eye of the pathologist, it looks very different. So we made some modification to the algorithm to adapt also to this type of images. We had very good success with recent samples, and by recent samples I mean samples that were generated from 2016 until now. Older samples had the stain faded in some of them, and they were not good enough. The algorithm failed in these samples, but actually the practical use of the algorithm for Hirschsprung would be a patient that is now in surgery and not for 8-year-old or samples. So we are very pleased with the ability of the algorithm to highlight the relevant areas. And you mentioned in the presentation the challenges during surgery, and sometimes the pathologist requires multiple samples, and it could be related to the adequacy of the samples, but it's a big challenge also on the pathologist side, even if the sample is adequate, and the ability to analyze quickly multiple scans of the slides. We think that it's something that might be also applicable. I think that even for a frozen section, I think there is big promise. We are pleased with the ability of the algorithm to deal with recent, which are the relevant type of samples. We also did something interesting. So we took 5 non-expert pathologists, and since we mapped the different presentation of ganglion cells in Hirschsprung disease samples to be a challenge, to be something that leads to misdiagnosis. So we wanted to see if we train the pathologists, we give them a very short training, less than 10 minutes, before they make Hirschsprung diagnosis. It was a short presentation emphasizing the unique appearance of ganglion cells in patients with Hirschsprung disease. So we wanted to see if this training would improve the diagnosis. So they did 2 analyses on samples. They went through a few hundreds of images that were recommended by the algorithm, and they gave them the score. So the first 2 analyses that they did were without training. We wanted to see if there is a learning curve between the first time they go through the images and the second time. So as you can see, there was no significant difference between the first and the second time. And before the third time, they went through a very short presentation, again, just highlighting the unique appearance of ganglion cells in Hirschsprung disease. And as you can see, they achieve a significantly better detection of positive and negative cells, and reduced significantly the number of cases of images that needed to be sent to a referral to an expert pathologist. So even with very short training, and for a non-expert pathologist, going through the dozens of slides of Hirschsprung disease, that's something that takes a few hours. Okay, so less than 10 minutes training is something that is reasonable and can make a significant impact on their ability to accurately classify the images that are presented by the algorithm. So this is also something interesting that we encountered during our studies. So the limitations, I mentioned them already. All the slides are affected by fading. It requires pathologist input. It's not a standalone, the algorithm. So one limitation, it does not say if there is a ganglion cell or there is no ganglion cell.
But that's by design. So our thought process led us, in the end, an expert pathologist, a human pathologist, need to decide what to do. We don't want the algorithm to decide by itself, this is the solution. We want the algorithm to provide all the data that need to be supplied to the pathologist in order to decide correctly. So this is the state of mind that we had. So it is a limitation, but it is by design.
And another problem or limitation. So in some cases, pathologists classified the image as positive ganglion cells. So this is also something that we need to think about. So the algorithm identified something that looks like a ganglion cell, and the pathologist, the non-expert pathologist, said, okay, this is a ganglion cell. So this case, I have ganglion cells. So this is also a challenge that we need to be aware. But it was very rare, this event. I think we had one case like.
When you talk about positives and negatives in the diagnosis of Hirschsprung disease, it can be confusing because You're
Yeah.
saying false positive, meaning a false positive identification of a ganglion cell, which is actually a false negative diagnosis of
Yeah,
Hirschsprung disease. And
yeah.
it's safer to make a false negative diagnosis of Hirschsprung disease because that doesn't then lead to an operation, right? That leads to a question, okay, this child has symptoms suggestive of Hirschsprung disease, but we think we've seen a ganglion cell. So what that leads to is maybe another biopsy or maybe using some other stains that have been used to help solidify the diagnosis. This is not as dangerous as if you had a false positive diagnosis of Hirschsprung disease, which then would lead a surgeon to do an operation that might end up turning out to be not the right operation, right?
Yeah, for sure. So that's a good point. And so here the false positive is what I meant in this slide. False positive at the level of the image. Okay, so it was classified as positive for ganglion cell, but by the non-experienced pathologist, and as you said, it's the lesser mistake, and nevertheless, even this lesser mistake was extremely uncommon in our cohort.
Dov, how many more slides do you have? Because I'd like to understand, most importantly, where you go from here. What's next? There we
Okay.
go. Beautiful.
You're aligned.
So future direction. So we believe that frozen section is a very important time point. You need a rapid response. The child is in surgery. The surgeon is waiting, and if we can improve the accuracy and the pace, the time required to make accurate diagnosis on frozen section, this would be good. So future directions that we think about are maybe taking samples. We use all the samples that we have for frozen section, but maybe getting samples from other medical centers, also younger, more recent samples, because we know that the algorithm fail in older samples, but we are not interested. We are not really interested in the older samples. So getting samples from medical center, that would be interesting. All the validation that we did is for medical centers in Israel. So international validation, that's something that would be interesting to do, to see how the algorithm works on samples on slide from international.
And do you need help getting connections to other medical centers? Is that something where you want collaboration, or do you have your own
Yeah, we would be
networks
happy.
that you're...
No, we would be happy. We would be
I
happy to
think
get samples.
the bigger picture is even more interesting. So currently, what we believe is that we have a tool that can provide very easily a quick analysis of what is the status of Hirschsprung pathology samples. So we want to make it accessible to physicians. We think we made a validation that this is good enough quality. It's just a suggestion. It's not forcing anyone. So it's not. I don't know if it requires FDA or any other approval. It just suggests what do we see, what do we find, so even it can help the parent. But then, how exactly to make it accessible to as many people as possible? We will be happy to make it accessible. Both me and Dov, from our personal level, we want to give it to as many people as possible. We need to verify with the hospital there is no issue with them, but besides that, we will be happy to make it accessible as fast as possible.
So I think that's great, and maybe ultimately the form that it takes is a is a software, web-based platform where there's an easy upload. Anyway, whatever ultimate form that takes. But it seems to me, and Jack, you need to weigh in here. It seems to me the way to approach this might be first to, as you suggested, just get connections with one or two additional medical centers just to further refine the algorithm. And also, get feedback outside of Israel. Seems like a logical progression. But Jack, I don't know what your thoughts are on.
I mean, I
that.
think there's a number of different ways this could be helpful. The first is just in the initial diagnosis of Hirschsprung disease. It's going to make things more efficient, right? Because people don't have to spend, as you said, an hour going over these biopsies and looking at hundreds and hundreds of sections. So it'll make things more efficient. But I think even more importantly, I think the application to developing countries where they really don't have pathologists, and still in a lot of the world, people are getting operated on for Hirschsprung disease based on a barium enema because they just don't have the ability to look at pathology. So this could have an enormous impact on those kinds of countries. And then the other thing is the frozen section application while surgeons are doing surgery. And I think, Eric, that's what you were talking about before, is you have to do multiple frozen sections, and that's where accuracy is more of an issue. When you've done a rectal biopsy and then you're just waiting, you can show it to a lot of different people, you can get other opinions, but when you are in the operating room, the clock is ticking. You're doing intraoperative biopsies, and you need to know, are there ganglion cells or are they not? Because that's going to determine what operation you do and whether you take out intestine. And I think that actually may be the more important ultimate application. So doing this with in real time, I don't know how you would set that up, but I think validating this approach intraoperatively using fresh frozen sections that are going to be better quality than the old ones, as you've pointed out. But that's going to be a bit more of a tricky validation process. And you can do that in Israel, but probably want to do that also in places that have an extremely high volume of Hirschsprung disease. Vietnam is a good one to start with. I was there years ago helping them in the operating room, and they see hundreds of cases every year just in the one hospital I was at in Hanoi. China is another place where they just have a huge volume of Hirschsprung disease. Some of the Beijing Children's Hospital, they did hundreds of pull-through every year for just in the one hospital for Hirschsprung disease. So that's something to think about when you're doing the validation of frozen sections. I think there's tremendous.
I feel like even so, the way you laid out the use cases and the applicability is very helpful, Jack. The way I'm thinking about it is more, it seems like it has achieved its intended use. The AI assisted pathologist expert system. Now they need more data. They need more samples. They need more geographies. They just need more refinement. And how do we help with that? How do we help? Because, in the US, we have connection. In the US and Canada, we've got connections to the Hirschsprung community. I also I'm not sure, but I think I recall Alan and you talking about the scarcity of Hirschsprung trained pathologists. So it seems to solve that problem as well. Like there's a scarcity of new talent And then the learning curve, as we know, is quite steep, given the, sort of the needle in the haystack you're looking for here. So I'm trying to think about how we can help connect Dov and Rami with the community that we have to take this algorithm further.
Yeah, I guess it's really the community of pathologists that are going to operationalize this. Do you guys, I missed the very beginning. So are either of you pathologists?
Yeah, I'm a pathologist.
Yeah. So you must have a network of people that you know everywhere, right?
Yeah, but not really for Hirschsprung disease. Yeah, but I think that maybe we can, I don't know, write a short summary of what we did, and if you can, through your connections, get a pathologist maybe from a large medical center with a large volume of Hirschsprung surgery, to and ask them, do they think this is something that could be useful for them, could be useful for a medical center with less experienced pathologists, and we will make every effort to make the algorithm accessible for them to implement it in the clinical practice. So I think that the next step for me in this it's a few years journey of Rami and myself, and I think the next step should be to translate this algorithm into clinical benefit, to evaluate it in the clinical practice, not just archived samples and things like that, but really clinical practice. So if you are able to make it happen, to help us make it happen, I think that would be a great next step.
Because I think what I would foresee is just a real-time validation where you have cases of Hirschsprung disease and you run it through the algorithm, and they also run it through the usual approach where the pathologist does it, and then just do a comparison of the accuracy. That to me would be the best way to validate it.
Yeah, exactly. They need more shots on goal. They need more at bats, whatever the analogy you want to use. You gotta keep moving this forward, otherwise it becomes just another research project.
Yeah. So actually, to make it more than a research project, what I describe it to a team here in NVIDIA, and the guys here told me that it will be an honor for NVIDIA to provide the hardware and to talk with Microsoft to provide the web interfaces in order to provide such a tool. And then in order to do that, we need a much more not business-oriented, but people that actually want to go to the field and provide it to hospitals to show them what we can do with this specific tool. Maybe after validation, maybe after we verify that it's good enough. But I think Microsoft and NVIDIA will be happy to cooperate in order just to provide to people. So that's from an initial test that I discussed with the NVIDIA team here. If they will be happy to help it, they will be very happy to help in doing such a thing. Happy.
Great.
To make it happen.
This was fantastic, guys. Congratulations on your progress so far.
Thank you very much.
So this is our team, and thank you for the support. Okay, and we also got support from Israel Innovation Authority.
Great.
Help make it happen, and also the medical centers that I mentioned. So
great.
Well, thank them for us.
We
thank you guys. Thanks for your creativity, your innovation, and let's keep going.